and we've got to put in a safeguard so that that doesn't happen. And at this meeting, I kept referring to that as a prenuptial agreement. You have to have a prenuptial agreement with these people. And so that was October. Then we go to the November hospital board meeting. And I thought, you know, I went into that November hospital board meeting confident that my persuasive speech at the healthcare district was going to turn this all around, because we were going to have all sorts of study sessions now on what is regionalization. And we get there and they said, well, okay, let's vote on it. And I was like, no, what about the prenuptial agreement? And it's like, no, it's not necessary, let's vote. And they voted. And that was the end of it. I made them do a roll call so I could get on the record that I voted no, but I was it. And I left that totally devastated, figuring this is over, this is all gone. And luckily by then, Greg Duncan had agreed to become chief of staff starting in January. And he saw how dejected I was, and he's like, no, it's not over yet. I'm gonna go dig into this and carry on from there. And so digging he did. And so he's going to tell the next part of the story. Thanks.
And I think if there are any questions for any of the speakers, feel free to interrupt me, or if anyone has questions for Kevin as we go along. My name is Greg Duncan, and I'm an orthopedic surgeon. I've been in Crescent City my entire professional career, which is 20 years. My wife moved up with me from UCLA, and we have 3 kids who were raised here, and 2 of them now off to college. So we also have a significant stake in the community. The position of Chief of Staff is a new one for me. It's not my nature, I guess, but Kevin asked me, due to the serious nature of what was happening on the board, if I would be willing to become the Chief of Staff, and I said I would. And it's been good for me. Number one, my fear of public speaking is getting slowly better. That's a true story. I want to introduce another term during this segment of the talk. The first term that you've heard tonight is regionalization. And what regionalization essentially does is dissolve the local board, which is 10 people, 9 of which are appointed by Sutter, and 1 of which is elected, so that would be the Chief of Staff. Under regionalization, that board is dissolved, and it is replaced with an advisory panel that has no decision-making authority. The board meetings would then take place in the region, and 1 of the 11 regional chiefs of staff has a vote on that board. So my point at the last board meeting was it clearly reduces the influence of the elected position from the community. And I couldn't even convince the president of the region of that. We go from a guaranteed ex officio board seat, which means I can vote at every board meeting, to once every 11 years, I can attend a board meeting 350 miles away. I couldn't even agree on that. And I looked at Mr. Cohill in the eye also at that point, and I said, Mr. Cohill, for the first 19 years that I was a Sutter-affiliated physician, I was proud to say that. This last year, after what Kevin had described, and during that meeting, I could no longer say that. Even that was not enough to convince anyone on the board to rescind their prior vote in favor of regionalization. And I'll conclude with the final chapter of that, which occurred last week at the end of this talk. So that's regionalization. Now we're going to introduce a new term, which is critical access. Critical access has been brought forward by the CEO of our hospital to the Board of Supervisors in a speech that he gave on 2/28/12 as a possible implementation here in Crescent City. And it's important for me, I'll just try to slow down, there's some information about this that's important, so please stop me if it doesn't make sense to you, but critical access is a federally funded program, and it was designed in 1997 to keep open tiny hospitals in remote areas. And what it does is provide tax dollars to the hospital no matter how much income they take in. So it was designed for hospitals that had 12 or fewer beds to reduce the inconvenience or even the lack of care in certain areas of the country where people would have had to travel great distances. The tax dollars were therefore designed to improve access to medical care. That's going to become important. The basic criteria are 25-bed maximum. At no point can the 25-bed capacity be exceeded. If a patient comes in and they're at 25, they have to be taken to a different hospital. We currently have 49 beds. There's also a 4-day maximum average stay. So if you present to the hospital with a condition that looks like it's going to take more than 4 days to correct, you will be transferred to another hospital. There's no negotiating those 2 points. Finally, it becomes optional to have a physician on duty in the emergency room. Currently, of course, we've always been staffed by an emergency room physician, usually 2 physicians, and even then it's very busy. Now, I'm not saying they would take that position out, but they could. And when you hear what I'm about to say next, it becomes more than a theoretical concern. So an example of a critical... Oh, go ahead, sorry.
Dr. Duncan, let me ask a question before you move on.
Yes.
Sir, you said there was a 4-day maximum average length of stay. Can you tell us what the primary diagnosis is for admission to the hospital is now, how long the average length of stay is for that diagnosis?
Mr. Souksi made a presentation to the Board of Supervisors, and that very question came up. And he said, we don't currently meet the criteria to be critical access. That's in the record in a presentation he made before the Board of Supervisors. The average length of stay, my understanding, based on data that Sutter's given me, which I'll be calling into question in a moment because some of the data they've given me is clearly not accurate, is 3.8 days. So it's very close to the maximum right now. So back to the presentation, a good example of a critical access hospital that works is Gold Beach, Curry General. It's a very small hospital and it's been able to maintain operation under the critical access program. In 2008, Sutter Health came up with the idea, and they were the first hospital corporation in the nation to come up with this idea, that they could also qualify for critical access by cutting beds. So instead of having a tiny hospital of 12 beds, qualifying in that manner, they realized they could take bigger hospitals and reduce beds and qualify. And that's exactly what they did at Clear Lake Hospital, Sutter Lakeside in Clear Lake, California. What that did was guarantee that all of the operational costs, including executive salaries, will be guaranteed by federal tax dollars. Go ahead.
Including executive salaries?
All costs, executive salaries, operational costs, infrastructure costs, are all guaranteed by your federal tax dollars.
Would any of that money go back to